Oh, do I want to sell my home? Maybe I should tell United Cerebral Palsy. All right. Well, Jeremy, how you doing with the setup?
Yeah, it's set up, and whenever you're ready, I'll press record.
All righty. Can we get Joanne unmuted?
I'm unmuted. I just want to know. I want to know who 7182.
I was just going to ask that.
00. Yeah. Who is that?
I have no idea.
Could you announce yourself, please? Unmute yourself, whoever you are. No? Maybe.
It's *6. If it's not a board member, you just move on. But if you're a board member, press *6 to unmute. And then, yeah, I did send a reminder out, Sandy. I just sent out an email around 7 o'clock.
Right. Maybe this could be the person from the Bronx Times.
Yeah, it could be. All right. So I'm going to press record if you're ready, Sandy.
Yeah, I'm ready. Dr. Boudreau, are you ready?
Absolutely, I'm ready.
Okay.
Okay, recording.
All right. This is it. Today is April 12th. This is a meeting of the Health and Social Services Committee. It's 7:06. I am Sandra Younger, the co-chair. And Joanne, you want to introduce yourself?
I'm Joanne Rubino. Well, you're not the co-chair, aren't you?
Oh, that's right.
Now? I'm the co-chair and you're the chair.
Right. I'm so used to that title that I forgot. All righty. And now we have two very important people from the Bronx Psych Center. One is Dr. Boudreau, and he'll give a little bit of background of himself. And then the next person will be Sherry Baird.
And Sherry is?
BAIRD.
Yes, I have that. What is her title?
She is the executive director.
Ooh, okay.
So we have the clinical director and the executive director.
Great.
All right, Dr. Boudreau, it's all yours.
Yeah, so good evening. It's a pleasure to come and meet with Community Board 11 in the Bronx to really talk with you about Bronx Psychiatric Center, which is at 1500 Waters Place. And I'm the clinical director of Bronx Psychiatric Center, which means that I oversee the quality of clinical services for our inpatient, for residential services, along with our outpatient clinic services. And I'll tell you a little bit about the services that we offer. And the reason why I'm speaking to you this evening is because we are very interested in being a wonderful community neighbor to the Bronx. We are in the Bronx, and we want to be a better neighbor and partner with our neighbors. And on the call,
go ahead.
What's that?
I wanted to say I've been trying to do this for a long time.
Well, you got us going. You know, COVID came, but you got us going. So we're moving in the right direction. We're evolving, Sandy. And I also have the pleasure of having my colleague, Sherry Baird, who is the executive director of the Psychiatric Center, who's on the call as well. And at any point, if anyone wants to ask a question, I'm flexible. Just let me know and we can talk. And this is a very informal and an interactive session. So here we are at 1500 Waters Place. This new Bronx Psychiatric Center is really an environment of healing. It differs from the previous Bronx Psychiatric Center that was here a long time ago. And the new building was opened and up and running in 2016. Here's just the names of our leadership team: Sherry Baird, myself, who's a clinical director. We have the director of inpatient services. His name is Mr. David Scott, who's a social worker by training. We also have the deputy director of community services, Mr. Lionel Hunt, who's also a social worker by training. We have Ms. Crystal Graham, who is our deputy director of facility administration services. And what her job entails is making sure that the environment is correct. We're following all the regulations with OSHA and the Joint Commissions and all the protocols, and making sure that there's a safe environment, not only for the patients to experience their healing, but also a safe environment for our staff members to work in. We have Ms. Ruth Camtha, who's a social worker by training. She's a director of quality administration. She makes sure that the quality of services and our adherence to state legislature policies and the joint commissions are, consistent. And then we have Ms. Martine Sainville Wilson, who's an RN. She's the director of nursing services. So our philosophy here at the Bronx is that we want and we are an integral part of the community continuum of care. And what that just means is that we are an aspect of clinical care that involves not only the state psychiatric centers, but also the city hospitals in the area, Jacoby, Monty, Einstein, North Central Bronx, St. Barnabas Hospital in Bronx, Lebanon. We have many city hospitals here, and also the community has a responsibility and a role to partner into the management of people with mental illness. So we at the Bronx Psychiatric Center pride ourselves. We want to be the model for best practices in the prevention, treatment, and recovery for the seriously mentally ill. And I want to highlight recovery, which is really important because the concept of recovery focuses on the person. It's person-centered. It identifies the motivational currency of the patient so that we can build upon our relationship based on what people are interested in and providing them with the tools to manage their mental conditions so that they can have a good quality of life in the community, just like we all want. We use state-of-the-art psychopharmacology here, which means medication management. We can use the best medications for some of the most treatment refractory conditions known in the mental health field. We use state-of-the-art recovery and psychiatric rehabilitation, and we believe in patient empowerment and also patient choice. We know that our patients have historically been marginalized and have not had a voice, so we want to provide them with a platform to really stand in their truth and speak to us about what they're interested in so that we can help them to achieve those goals. We have a recovery-oriented inpatient care unit in that we connect with our Article 28 providers in the Bronx area.
Dr. Boudreau, if I may, do you also
Yes.
work with the families with the goals of the patient?
Oh, absolutely. So, part of talking about the community really focuses on the family and personal involvement, right? So many people with mental illness, they burn the bridges with their family members. Family members don't understand the mental illness. The patient may not understand the mental illness. They may engage in some behaviors that might seem criminal and bizarre, so they alienate themselves from the family, and the family doesn't know how to love them or be there for them. So part of what we do here is really getting the family involved and trying to bridge the gap in the relationship between our patients with a serious mental illness and their family. We have noticed that when families are involved, the patients may have more of an investment to do well and to comply with treatment. So we bring them on board. We have them involved with education about their loved one's mental illness. We give them some tools so that they can be a resource, a stabilizing resource for their family member while they're in the community, and really to help connect them with us so that we can better help their loved one, because it takes a village to really help our patients with serious mental illness.
Great.
So a little bit about our campus. Our campus, it's not only Bronx Psychiatric Center that's on here. We have a couple of other agencies that are here, which is kind of like representative of the continuum of services. I'll tell you a little bit about that. All right, we have a very progressive campus focusing on the continuum of services. We have a transitional living residence, a recovery center, some peer services, our Ginsburg Wellness and Recovery Center, our Haven House, which is very unique residential center that I'll tell you a little bit about, and our Pathways team that we'll talk a little bit about when we focus on community services. So our inpatient unit, Bronx Psychiatric Center, is the adult inpatient, so anyone from the age of 18 on up who might have a mental illness can receive inpatient psychiatric treatment at our facility. We have a capacity to treat 152 patients on the inpatient service. Our hospital is divided into 6 inpatient units. We have a 2 North co-ed unit. We have a Hispanic unit because we're in the Bronx, so we should be at the seat of Hispanic culture here. We have a transitional unit, 3 North unit, which is used for some of our patients who may be known as the CPL 33020 patients. Those are the people who may have had a mental illness and committed a crime and maybe was in a prison system or a maximum security forensic hospital, but now they're receiving inpatient services with us so we can reintegrate them into the community. We have a 3 South co-ed unit, and then we have 2 other male units on the upper floors. One is just an admissions unit, the other focuses on cognitive behavioral therapy to help the patients. So a total of 152. And our patients, the way they're admitted, they don't just come off the street. So like at Monty, patient can be brought in by EMS from the street, from a shelter, and they can be evaluated in the emergency room at Monty, and then there's a decision made about admission. We're a bit different. So the city hospitals, Monty, Jacoby, North Central Bronx, St. Barnabas, Bronx, Lebanon, St. Vincent's and Westchester, the city hospitals, they initially hospitalize the patients with a mental illness. Wow. And they're providing them with treatment there. And if the city hospital believes that the treatment might take longer than they're able to treat the patient, then they will apply for admission to the state psychiatric center. So we have hospitals who are filling out documentation for referral to Bronx Psychiatric Center, and the information they provide us has to do with the patient's mental illness, how they got to the city hospital, what are some of the treatments that the city hospital is providing for the patient, and how is that treatment working or not working, and why they're seeking a referral to our state psychiatric center. The goal really is not to have patients hospitalized for like 10 years or 11 years like they did back in the day. Since we have more robust treatments available and community wraparound services, the goal really is to get them in, to stabilize them, and connect them with the wraparound services in the community so that they can do better. The problem is that with some of the city hospitals, they may not necessarily have access to the community services. But we as a state, we do a lot of investment into community wraparound services for patients with serious mental illness. So the city hospital will apply for admission to us. Our philosophy really focuses on hope. We want to be the beacons of hope for our patients, and we want to help our patients to get stabilized so that they can have some semblance of normalcy in the community. But there's some work that we got to do to get there. So when the city hospitals refer to us, we have a team that consists of myself, the head of the Department of Psychiatry, the associate clinical director, the medical director, the director of inpatient operations. We have social work staff and admission staff, and we review the referral packet from the city hospital, and we read it and we say, okay, well, this patient is at Jacoby, and this patient is having some auditory hallucinations and paranoid delusions. It's not simply getting better with Haldol. The patient's on a low-dose Haldol. So we reach out to the city hospital and say, yes, you're applying for admission, but before the patient can come to us, we want you to consider trying the patient on a long-acting injectable medication because the patient has a history of not taking medications while in the community, and also possibly considering the medication clozapine, which is one of our most effective medications for people with treatment-resistant psychosis and violence in the community. A lot of our patients have had some episodes of violence, and the city hospitals tend to refer patients who may have violent histories towards themselves or others. And so we make recommendations to help manage the patient in the city hospital. And then we monitor, and we continue to have a dialogue with the city hospital and monitor the patient's progress or lack thereof. Sometimes we have patients who are considered very high risk and they need a lot of services. So what we will then do, OMH has a New York City field office, and we will connect the city hospital with the New York City field office, and we will have a high-risk meeting. And the high-risk meeting consists of maybe about 12 different providers or representatives from the field office, from Children's Services, ACT, Assertive Community Treatment Services, Assisted Outpatient Treatment Services, and a number of other services who really take a look at the clinical picture of the patient and assist the City Hospital and Bronx Psychiatric Center in generating a treatment plan that will be effective for the patient once they come to Bronx Psych Center. So we have a connection with the field office to help us and guide us in the patient's treatment. We also get referrals from forensic designations from some of our maximum security forensic hospitals. In our area, we have Kirby, which is on Ward's Island, and oftentimes we have cases that come from Mid-Hudson. Sometimes we have cases that might come from Rochester, and those may be for patients who might have lived in the Bronx or family in the Bronx. And so those patients have been stabilized at these maximum security forensic hospitals. They've oftentimes have spent a number of years, anywhere to 5 to 10 years, before even getting to us. It's our job once they get to us to make sure that they're stabilized and to gradually reintegrate them into the community, which also takes years. And then we also get our forensic designations from New York City Department of Corrections and New York State Department of Corrections. So we have patients who might refer from Rikers, who might come from Sing Sing, Attica, wherever, and they will be referred to us for treatment. Oftentimes, the patients that might be referred from a city hospital, they've had a serious mental illness, and they may have completed their time for their incarceration. But it has been decided that they would need treatment and care in a psychiatric facility before they can return to a community. So they refer them to us, and then we stabilize them and treat them and ultimately discharge them to the community at some point.
How many of these patients are at Bronx Psych under Article
the CPL 33020 patients? So
right.
We have our CPL 33020. All of those patients have committed a crime in the context of their mental illness and have gone to court and have pled not guilty by reason of insanity or mental defect. So we have an entire inpatient unit that focuses on those patients, and we have a few of them that are also in the hospital. But then we also have patients who are known as CPL 730 final patients, and those are patients with mental illness who may have committed a misdemeanor, and they're not going to be kept in jail for long, but they're not deemed safe enough to return to the community, and we can get a lot of those more frequently. We usually have help with some of the other city hospitals in managing the CPL 730 final patients, but if they don't get better in the city hospital, then they send them to us. And this is a program that New York State Office of Mental Health and New York State Division of Forensic Services has partnered with the city hospitals in order to kind of like provide the service of screening the CPL 730 final patients before they're referred to us.
Thank you.
You're welcome. So our referral form, I talked about that. We take a look at all the treatment, medical, psychiatric, their legal status, and most recently, COVID-19 vaccination status. Every patient who comes to this hospital, referred to this hospital, we want to know if they're up to date with their vaccinations, meaning they've had both Pfizer's or both Moderna's or the Johnson & Johnson, and if they've had a booster. If the patient has not been vaccinated, when we admit them to the hospital, we will admit them we have an isolation unit that we created here that's separate from all the other inpatient units, and we will offer them the vaccine on day one of admission. And our goal really is to get them vaccinated and boosted while they're here in the hospital, because it's going to be to their advantage to have that once they return to the community.
So I have a question.
Yes.
The homeless issue, I knew you probably knew this was going to come up, is really a big problem in the city, in the Bronx, everywhere. And Eric Adams said that he wanted to increase the number of long-term beds or beds, beds like what you described, where the holistic approach, where you're treating a patient, where you're trying to get them out in the community, but not before they're ready and so forth. Has there been any talk of increasing the amount of beds?
Yeah, so I've heard a little chatter about that. So Eric Adams is working with the Department of Health and Mental Hygiene,
I see.
DOHMH, and OMH to talk about the possibilities. They're creating like some kind of like respite crisis centers
I see.
for the homeless initiatives. But also, we've also been OMH has been working with city organizations to go to the train stations and
Oh,
assess and engage people with mental illness to try to get them in care so that we can stabilize their mental illness and get them into housing because there are social determinants of health which has an impact on someone's mental hygiene. So not having a place to stay that's stable and safe, not having food in your pocket, not having anything to do, not having any connections, not having medications, that really is a recipe for disaster. And a
mhm,
lot of our homeless people
absolutely.
have that. So engaging them is what they're trying to meet people where they are, not here at the brick and mortar, going out and meet the people where they are and getting them connected with services is what they're trying to do.
Now, how about
Uh,
substance abuse? How do you deal with that? Is that a different arm? Because that can be mental illness as well, you know,
It's all the same arm.
treating,
So,
yeah,
mhm.
treating,
so we
self-treating.
so when I speak about mental illness, I'm also referring to substance use disorders.
Mhm.
Most of our patients, I would say that 98% of our patients here have experienced some trauma here at this hospital, and maybe in most psychiatric centers. And people who have experienced trauma, sometimes they try to figure out ways to numb themselves from those
Of
experiences and
course.
reliving those experiences.
Mhm.
And sometimes they turn towards substances like alcohol or like opioids or like
Mhm.
K2. So, and using those substances in and of itself can exacerbate an underlying mental illness like schizophrenia, a bipolar disorder. So we
Sure.
can't separate them. We got to treat the whole person.
Mhm.
So we will treat the substance use disorder along with the medical condition because that is important. That the medical piece, oh my God, it is really key. Our patients are stigmatized, because people don't understand them and people might fear them. They may not necessarily get the best care. And so we at OMH try to provide integrative care. So we have medical, psychiatric, and substance use treatment for our patients, not only inpatient, but also in the outpatient realm as well.
Okay. Thank
Thank-
you.
You're welcome.
Oh,
Yep, another question?
I was going to ask that I know, but I would like you to tell the people listening how on psychiatric is helping with the homeless crisis, say in the subways, etc., or dealing with patients who might be mentally ill. Remember, they asked for volunteers to go out in the
Yeah,
field.
yeah. So we have many OMH employees from Bronx Psychiatric Center who are taking shifts at patrolling the subway platforms to engage patients, engaging people. So it's really about how do you engage someone to connect with them, to link them up with the services that they might need. Some people, because of their illness, they may be very paranoid. They may not be trusting of someone coming to them. They may think we're trying to kill them or poison them. But just because they have those symptoms should not prevent us from engaging them and helping them. We have access to things that can be helpful, right? So what they might try to do is, take a patient to get some coffee or to get a bite to try to connect with them and talk with them or sit with them in the park, right? Because, bringing a patient to a psych center can be traumatic for some people, right? They may have had negative experiences before. They may have watched the movie One Flew Over the Cuckoo's Nest.
Oh,
And they
God,
might
never.
remember back in the day and say,
one
I
of
was
my
going in a
one of
place
my
like that.
favorites. Well,
Right? Right.
there are no nurse ratchets at Bronx Psych.
Nurse Ratched, yeah. So, so people are concerned and like, oh my God, I'm gonna go here, I'm gonna go and die in a hospital. So even people with mental illness have a stigma about coming to a psychiatric center and outpatient clinic. So meeting them where they are may be the entry point into getting them into the kind of care that they need. So we have several staff members. In fact, I have volunteered to go. So hopefully within the next few weeks, I will get an opportunity to go and lend my support, get a chance to see how the teams are doing, and maybe to provide them with some insights about how to manage some of our most seriously ill people in New York State.
Well, I want to thank you for volunteering and also express my thanks to all of the workers who are volunteering in this issue.
Absolutely. Yes. No, it's all hands on deck. So COVID-19 taught us it's really all hands on deck.
Mhm.
And when we
Absolutely.
are cohesive, we can really be effective because it's the cohesion that allows for innovation and creativity and really effectiveness in whatever we put our minds to. So, yeah, we're trying to do that here. So, once our patient from the city hospital or from the forensic facility, once we reviewed them and made the recommendations and the patient's still not getting better, then we arrange for the patient to be transferred here and we provide them with treatment here on one of our inpatient units. And then once they're stabilized and we connect with the families and we are addressing the substance use disorders along with the medical disorders, we apply for discharge into the community. And that varies depending on the person, their strengths, there is an improvement, and the level of illness that they have. Not all of the patients who come here, will have schizophrenia, but most of them will have schizophrenia or schizoaffective disorder. We have some patients who are severely depressed and suicidal, who've had jobs, who've worked, done on Wall Street. I mean, just a many different types of people, but most of our patients have serious mental illness, and we provide uniquely tailored treatment for every individual who comes here because that's important.
Hmm.
And what is the process once they are discharged into the community?
My
What is
next
the
question too.
aftercare?
Yeah.
Yeah, so there's a big process for it depends on the person, right? So if the patient doesn't have any housing, we look at different housing programs. One of them is our housing program, our transitional living residence, which is staffed 24/7 with staff members that are there to provide supportive services for the patient. We get them outpatient treatment. Oftentimes, it's at our White Plains Road Clinic, and it's affiliated with us. It's our system. So there's a facilitation of information from inpatient to outpatient. We also give them community support services. Some patients have what's known as embedded pathways. It's a team of providers who connect with the patient while they're on the inpatient unit and work with the patient for up to 9 months once they're discharged to make sure they're making their appointments, they're getting their Medicaid, they're getting their entitlements, they're meeting their medical doctor, they're going to the vocational center that they've been enrolled in, they're going to the psychosocial club. And what we also try to do is make sure we know what a patient's interests are. So if a patient is interested in vocational training, we're going to find a vocational program for them. They're interested in going back to school, we're going to have them working with a career counselor to help them with that. We even have a residence on our campus that focuses on that. If they're trying to get their GED, we're going to start the GED process on inpatient, but continue it in outpatient so that they can get their GED. It's important that we teach our patients that despite your mental illness, you can still work and have a life that's worth living. You may not believe that because you haven't had the opportunity to do that, but we have a responsibility to teach them about that and to create that for them because it is possible. We also have some patients who might be discharged to their family's home. Some have had their own place of residence before, their own apartment that they still paid for while they were here on the inpatient unit, so we can discharge them there. And we try to really partner with other organizations in our Bronx area who can treat our patients, right? And our patients meaning those with serious illness, the voiceless, the hopeless, because it takes a certain agency organization to be able to work with our patients. I think you wanted to ask me a question, Ms. Joanne.
No.
Oh, okay, all right.
No, I
And
understand.
for some of our patients, we for those who we know have not when they get out, they're like, I ain't taking that medicine. I don't care what they do. I'm just gonna take it while I'm in the hospital. But once I leave, I'm not taking it. On our end, before they're discharged, we put them on an injectable form of a medication, antipsychotic medication that they get once a month. They're required to get it, and we take them to court. There's something called assisted outpatient treatment.
Wow, I did not know that.
Oh, yeah, I knew that. Yeah.
So it's assisted outpatient treatment. We petition the court. We say, listen, this person has a history of mental illness, and within the past 3 years prior to being admitted here, he or she has not been adherent to their treatment, and they've required a hospitalization at least twice in 3 years. And or they, in the context of not complying with their treatment in the community, they've been violent or have threatened violence towards other people for 4 years prior to them being hospitalized with us. We believe that they need you to order court mandated treatment to tell them, listen, you're being discharged from Bronx Psychiatric Center. You have a whole treatment program. If you don't pick up your medication, if you don't make your appointments, we're going to send the AOT removal team to find you, pick you up, and bring you to the nearest psychiatric emergency room to determine if you need inpatient psychiatric admission. That is assisted outpatient treatment based on Kendra's law. And so we utilize that here in the Bronx. We work with the Bronx courts. We have a court here in our hospital, and we take patients to court for assisted outpatient treatment if they're eligible and if they can benefit from it. Now, we don't look at it from a punitive perspective. The way we explain it to the patient is that this program is a resource for you to have a good quality of life in the community. You're going to have a case manager who's working with you, checking in with you, helping you to remain in the community. We're not interested in you being in and out of the hospital. And if that is not an interest of yours either, then we will assign you to assisted outpatient treatment. And so that's what we offer to them.
With the court-ordered medication, they go to the White Plains Road Clinic to get the shot, correct?
Yep, they go to the White Plains Road Clinic to get the shot. But sometimes we can refer them. So say they might, go to Manhattan, right? Say, oh, I want to live in Manhattan. I have a place in Manhattan. We will apply for assisted outpatient treatment for them in Manhattan. They might go to the Manhattan Psychiatric Center Clinic on 125th Street and get their injectable medication that's there.
And I know that it is effective and it works.
It is effective. It works. Sometimes, the city hospitals, they may be like, oh, you got an assisted outpatient treatment patient. Yes. So you have to help us with that. So, but it's about relationship building with the city hospital to making sure that they are evaluating these patients for admission and working with us so we can get the patient back into inpatient care. Right. So that's, you're welcome. So that's Bronx Psych Center. Also on our campus, we have New York City Children's Center, Bronx campus. Yeah. So we have the Children's Hospital, which is adjacent to the adult hospital. And the Children's Hospital consists of 3 inpatient units that have up to about 35 patients. And New York City Children's has 3 campuses. There's Bronx, there's a Queens campus, and then there's the Brooklyn campus, which is just an outpatient. But the Bronx campus is the one that's adjacent to us. And they treat about 35 patients. And these are people who are younger than 18 years old who might have mental or emotional difficulties in their receiving inpatient treatment on the campus.
So let me get this straight, Dr. Boudreau. It's who is really in charge of the New York City Children's? Is it part of the OMH or for the state, or is it really separate?
No, it's part of OMH, but they have their own executive director and their own clinical director and their own team. We share some services, like we might share housekeeping, dietary between the hospital, and environmental services, but everything else is separate. The units are separate, the hospitals are separate. They're still under OMH, but it's for the Division of Children's Services.
Thank you.
Okay. Also on our campus is our residential program. So we got two inpatient hospitals, one for adults, one for children. Bronx Psychiatric Center has, residential services. We have Bronx PC Transitional Living Residence, which it's two 48-bed residents, so a total of 96 beds, for patients with history of mental illness who have met the criteria for discharge. They have their own room. They're fed. We have dining services that are there for them, case management services, supportive services, rehab services. There's nursing involved, so there's medication management. Most of those patients receive their outpatient treatment at our White Plains Road Clinic. So we have a van that takes them to their clinic appointment and then brings them back. And some of them also have treatment at some of the psychosocial clubs like Fountain House or Lantern House, or the PROS programs, which are like programs designed to help people with mental illness and engaging them in groups. We also have a specialized residential program known as Haven House. And Haven, the letters Haven stands for Healing and Vocational Empowerment Network. And this is a 20-bed residence, so it's smaller than the others because it's a unique specialized program. This program focuses on vocational services. So if you want to get a job, if you want to do your resume, if you want to have interviewing skills, if you want to be part of the token economy, Haven House is a place for that. And some of our patients who, have come from, our CPL program, which are not guilty by reason of insanity. Some of them are high functioning, where they're highly motivated to change their life and do things differently, and a lot of them want to be involved in a program like that. Or we have some patients who didn't realize that they had strengths and skills, and we've identified that for them, and we put them in a program like that to help them to thrive. We currently have a couple of patients who live in the Haven House, who work for Amazon, who work for DHL. I think somebody is applying for a job at like a news station. So they get jobs all over the place. So it's really nice. And it's nice that it's on the campus because it gives the patients who might live in the other residential centers some inspiration and some hope about some possibilities for them. They're able to see that with someone on the campus.
How long can they stay at Haven House?
Oh, I think at Haven House, I think it's up to 9 months at Haven House. And because Haven House and also our TLR, they're temporary residences. So they're there to transition into the community. They're not fully into the community yet because they're on our campus. Once we assess their needs, assess the improvement that they've made, we then might apply for permanent housing, and that might be into the community. But they can stay in our transitional housing for a Haven House for 9 months. TLR, we try to get them out in 9 months, but we have some that have been there for a couple of years because that's the level of housing that they need.
Oh,
Thank you.
This is just a picture of our transitional living residence. It's beautiful, state of the art, beautiful. They have their own rooms, share rooms there. They get their dining services, and there's activities and group programming. We do group programming there. We do smoking cessation campaigns. Sometimes we have a psychiatrist and an internist from our White Plains Road Clinic to come directly and see patients there at the transitional residence, and that might be for some of the patients that might, be a little harder to treat. They might need more engagement. And this is just a picture of our Haven House, which is right across from the TLR. It's a 20-bed unit.
Thank you.
Also on our campus, we partner with another agency. There's the Bridge Community Services, and they have a 48-bed residence on our campus. It's known as the Bridgewater Residence, and these are 48 studio apartments of high functioning people. So these people have a studio apartment with a dining area, kitchen with microwave, stove, oven, a refrigerator, cabinets. They have all that in their own bedroom and bathroom. all in their apartment, which is different from our TLR. Our TLR is for patients who might need support and who need help.
Is this
The
permanent?
studio-
Excuse me.
the studio apartments is actually, it's not permanent. It's also a transitional housing, but they can stay there for a year to 2 years.
Mhm.
And because
But
the bridge has permanent housing in the community. So they try them out here, right? So if I say I have a mental illness, but I'm high functioning, I can cook, I know how to shop, I know how to pay my bills, I could be housed in the Bridgewater residence in that studio apartment. They see how I do, make sure I'm not using drugs, alcohol, taking my medicine. And then they say, okay, listen, you wanted to live in Brooklyn. We have apartments in Brooklyn that has a full living area and stuff like that. And we think you've done well enough in our program. Why don't you go take a look and let's see if you can transition from the Bridgewater into the apartment in Brooklyn. And that's what they do.
but I think it should be known that the Bridgewater is not really part of the state.
It's separate.
It's
No.
separate. Right.
It's totally separate. It's run by the Bridge program. It's a totally separate program. Sometimes we may refer our patients from, say, a TLR, our TLR, to the Bridge. We have to apply. It's a separate program. And they, they have to, our patients who might come from the TLR have to demonstrate that they can take their own medication, manage their own money, and know how to cook their own food, feed themselves, because they don't have dining services that are there.
Huh. Very good.
They're beautiful apartments. I've seen them.
They're very beautiful, very nice. They're very beautiful, and it's nice that the people can live in a nice place. Hopefully, it helps with the healing, right? Makes them feel good about themselves.
Right.
And part of the rehabilitation services is for them to demonstrate how they take care of their apartment.
Right, but
Oh.
my biggest concern was that when anybody would say, well, he's a patient at Bronx Psych, we saw him walking to Bronx Psych, he may not really be, or she may not be a patient at Bronx Psych. It could be the
Absolutely.
Bridge. It could be another facility that's on the grounds.
Yeah, and I'll tell you about those other two
Right.
facilities that are on the ground. So the Bridge is one that's not connected with Bronx Psych at all. It just happens to be on our campus. We share the space with them. Well, this wellness center, this is Sandy's going to be helping us with this project. We have advocated to have services that can be used for anyone in the Bronx community. We want to provide services like Tai Chi, yoga, wellness, soul cycle, Peloton, dance therapy, fashion therapy, cooking service. We want to provide that and partner with community stakeholders to be vendors within this space, the Wellness Center, formerly known as the Ginsberg Clinic, and have people from the Bronx community utilize the services. Only a select few of patients who might live on the Bronx campus may have the privilege to participate in those services, and those patients would have to be comply with the treatment, not using any drugs and alcohol, stable, going to their program and this and the other, and that they can appropriate and can benefit from the services. But this building will be our, what we hope is our connection with community stakeholders that can provide services for everybody and not people with just serious mental illness. And hopefully it can bring people to the campus, and it might encourage people to be open to interacting with people who might have a mental illness, and maybe to destigmatize and demystify what goes on this campus is by offering a service to them. So Sandy's going to be helping us with that. We're going to have hydroponics. We have hydroponics. We're going to have.
They have their greenhouse.
They have our greenhouse.
They have an industrial kitchen, which I would love to have it open to the public, where some of the patients could learn some skills and trade, and that people could come into the cafeteria and eat, etc. And possibly use the Ginsberg for meetings at night.
Absolutely.
Oh, meetings. No.
Yes, there's ample space for like community meetings. It's a beautiful space, and it's a state of the art design, right? So we're working We have a meeting on the 26th that's going to be coming up, and we're connecting with philanthropic organizations who want to repurpose buildings so as to provide some of these supportive healing services to communities who are dealing with mental illness.
Right.
One of our other neighbors that's on our campus is an OASIS program. That's the Office of Alcohol and Substance Abuse. This is called the Bronx Addiction Treatment Center. It's right across the roadway, but on our campus from Bronx Psych Center. It's a 28-day rehab program that's designed to treat 38 patients at a time. So the patients are receiving substance use treatment at this place. It's not at all connected with Bronx Psych Center. If we have some patients who might be appropriate, we have to apply for them to receive services there. But anybody can receive services at this Bronx Addiction Treatment Center, and it's being run by OASIS. It just happens to be on our campus, and it's probably one of the first buildings that you might see if you're driving on Waters Place.
Right.
All right. And then the last of our little neighbors on our campus is one through Catholic Charities. It's the Beacon of Hope Residence, and it is a 78-bed residential facility that has staff 24/7, just like we do at our transitional residence. It's supportive housing. It's run by Catholic Charities. Last year we had Cardinal Dolan to come in. We met with him there. It's kind of like talk about the services. Sometimes we refer our patients from the Bronx transitional residence to the Beacon of Hope. It's also transitional residence. So they have a token economy there. They make sure the patients take their medicine, not using drugs and alcohol, doing their programming, and moving up. So in this program, which might be a little different from the Bronx transitional residence, this program, they provide meals for their patients, but the patients might share rooms. But as the patients demonstrate that they're doing well, and as they're moving up into the program, they can then be moved up to the independent suite, where they have a suite with other high functioning people. They have their own kitchen, living and dining area. They do all their own shopping, cook all their own food. So it's a bit different from our TLR, where we have to feed our people. There at Beacon of Hope, as they get better, they have more independence within the building. And then once they have graduated from the program, then they're moved into permanent housing that Catholic Charities has all over the Bronx.
Very nice.
So
That's-
that's a Beacon of Hope. Yeah, it's a nice collaborative, and we have a good relationship with them. During COVID, we vaccinated Bronx Psychiatric Center. We created a mobile clinic, and we vaccinated the staff and patients at the Beacon of Hope, at the Bridge, and also at the Bronx ATC. And we also provided mobile vaccination to other agencies in the community. The Office of People with Developmental Disabilities. We went out, had mobile teams to go and provide vaccines there. And of course, we vaccinated all of our patients at our White Plains Road Clinic, and even with the Monty system, because Monty, at the Einstein, at one point, they didn't have vaccines available to them for their psychiatric patients, for their psychiatric outpatients. So Bronx Psychiatric Center, we created a mobile team that went and would vaccinate the patients at the Einstein outpatient program. We have an off-campus residential program. It's called Family Care. It's not on the campus. It's out in the community. These are people like you and me who say, you know what? I have an extra room in my house, or 2 extra rooms in my house, and I really want to be helpful to people with mental illness. So I will go get training to work with people with mental illness, and then I'll be the provider for them. I will make sure that they have their food, make sure that they have their clothing, take them to their appointments, and treat them like a family member. It's called Family Care. And this program might be designed for some of our older patients who may not do so well with the hustle and bustle of all the activity at the transitional residence. They need a low stimulating, calming environment and actually live in a home. And we oftentimes try to pair patients with a provider that may be of a similar culture, or a provider who might be humble to their culture, cook their food, speak the language. And we know that being connected with people that are familiar to you can lead to healing and can motivate for treatment. So we have about 130
Wow.
something family care providers in the community, and they're spread out all over the Bronx.
Wow, I had
Uh,
no idea.
we
But
have
and they
those
have to
providers.
pass, rigid and very important certain, criteria before they can get into family care. You just can't say I
Absolutely.
want to take somebody in.
Right.
No, you
Yeah.
have to be trained and certified,
Like,
and
Almost like
we
a foster family for children,
yeah,
for older people.
absolutely, that's exactly right. I
that's
used to
what
work
it
for
is.
ACS, so it's the same thing.
Oh, okay.
Yes, foster for like adults, and we have a team to go and inspect the homes, make sure that they're safe, and they say what it is that they say that they have, and our staff on a regular basis visits. We have family care staff members who go and visit the providers and the patients to see how the patients are doing, making sure that the providers are treating them well, make sure that the houses are up to date. And these providers, they get money from the state to help out state
Oh,
psychiatric patients.
sure.
Right. And does it just for a point of information? Doesn't the room have to be a certain size, etc.?
Yes, we have parameters. Yes, so we have a team that goes and evaluate the space to make sure that it's a room that's appropriate for our patient. There are certain environmental parameters that they must meet before a patient can be accepted there. The good thing about family care, so say for instance, if there is say we have a patient who's in family care and they're paired with a family and things wasn't working out as well as they had hoped after being there for 2, 3, 4, 5 months, we have the ability to take that patient from the family care and bring them to our TLR
Oh,
until
I
we
see.
find
Right.
another residence for them, right? Or there may be some other family care providers as well. So a little bit about the community services. We have an outpatient clinic that services over 650 patients. It's at 3050 White Plain Road. We have staff members at the outpatient clinic that consists of psychiatrists, nurse practitioners, nurses, social workers, licensed mental health counselors, internists, um, let's see who else, rehab counselors, and psychologists, and intensive case managers who work at the clinic to provide outpatient psychiatric care for our patients. It's the next level of treatment with less supervision. And these people are living in the community and going to meet their treatment providers to get the treatment to maintain their psychiatric condition. We also, in the White Plains Road Clinic, we have something called an Assertive Community Treatment Team. This is a team that consists of psychiatrists, nurses, rehab counselors, social workers. But instead of the patient going to the clinic to get those services, that team goes and meets with the patient wherever they may live. They can be living in our TLR. They can live at Aunt Susie's house. They can live, in another residence. And so they're provided with substance use treatment, medical treatment, psychiatric and psychological treatment. And that treatment is called the ACT team, Assertive Community Treatment. And the team goes and meets with the patient. The idea is that once the patient does better, transitions better into the community, then they can graduate to going to receiving services at the White Plains Road Clinic, right? But some people need a certain level of care that requires a treatment team goes and meets with them wherever they live to provide the treatment. That's the ACT team. We also have another state-run program called the Mobile Integration Team. And this is a support team that primarily consists of maybe rehab staff and social work staff that make sure that the patients going to their appointments, need a ride to the doctor's appointment, and make sure that the information from the psychiatrist to the internist, is made. Make sure that they get their entitlements and go to all their appointments, and try to connect them, and making sure that if there are any community stressors for them, that team is helping them to manage and to reduce the use of emergency departments. That's what the mobile integration team is for. The city has a similar team. It's called the IMT team, but that's run by DOHMH. OMH has a mobile integration team. And then we have the Health Home Care Management Program, which is just some healthcare teams, consists of intensive case management, care coordination, health promotion, and these are teams, another layer of community support. These are wraparound services for our patients with mental illness, just to make sure they're not getting into trouble and not having to go to the emergency room all the time. There's someone that's there, that's available, that's with them every step of the way in helping them to engage in their treatment. And that's a health home care management team. I mentioned a little bit earlier about the Embedded Pathways program. That's another program that we have here. And this is a program. It's a team that can come. It's an outpatient team that will come and meet a patient on an inpatient unit at our state psych center, but also at the city hospitals, and connect with the patient while they're inpatient, develop a relationship with the patient, and then helps the patient to transition into the community and provides all the support services for them for up to 9 months after discharge. And this program was designed to prevent people who are recently discharged from state psychiatric centers and now even city hospitals from falling through the cracks. Because sometimes when patients were discharged from the state psych center, they may not have made it to their first appointment. And then they can spiral downwards. So the Embedded Pathways teams helps to prevent that.
Well,
I like that.
well,
Singing?
it's the Looney Tunes, right? I want
I'm
to
in my head, I'm singing it.
I want to thank you for a very informative, interesting presentation. And I think it gave, I guess, the people listening in or watching a lot of great information that they may not have been aware of.
Well, I just want people to know that, we're really interested in being the beacon of hope for our patients, but also to be good community partners. We want to be great neighborhood members to our Bronx community, and we will do all that we can to achieve that. And we're here for the people. We serve the people.
Okay, I think that the wellness center is
Yeah.
going to really help with that. People get,
Yes,
get familiar with your facility or all your facilities.
I've been
Yeah.
trying to get this on for years behind the scenes, believe me, with Joanne. So I'm
Excellent.
really happy that we're going to have that meeting.
Well, it was actually through Sandy pushing us because she had the vision about Ginsburg. Ginsburg is staying there, so it was from her speak to us that because she sits on our board here, our board of visitors. We petitioned the state and said that the voice from the community says we need to utilize this building to provide services to bridge the gap between OMH and the Bronx community. And we want to do that. We have some ideas about it because the state was going to allow someone else to just come in and use the building, just like they did with Bridgewater and Bronx ATC. But it was through Sandy's pushing that we advocated to have this building and then to hopefully be very creative and provide some worthwhile services for everyone.
Go
Thank
Sam.
you. Yeah, well, we do it quietly because I don't, always.
No, she wasn't quiet when she was nudging me. I had to get it. She beat me. So
But
I got
this
it.
one, I really, well, hopefully I will live to see it through.
Oh,
I'm not getting
goodness.
any younger, but I want to thank you again. And I know that there are people who have been listening in and called in. Do they have any questions?
If anyone has any
This
questions,
is
uh-huh.
Roxanne Delgado. I have questions for the presenter as well as the community boards. I'm not sure which one I'm able to ask first.
Well, ask Dr. Boudreau first, Roxanne.
All right, I will do so. First, I'd like to state that this is one of the best presentations I've ever seen. It's quite impressive. I'm
Thank
sorry I
you.
arrived kind of late, but I like to ask if this question wasn't answered or if it was answered, I do apologize.
That's
What
okay.
What is the percentage of clients or patients that you have that are outpatient versus inpatient? I would think it's small. Am I correct there?
So our inpatient, yes. So we have 152 patients that are inpatient. And when we say they're inpatient, they're on locked units, which means that they cannot leave the hospital until they're psychiatrically cleared to leave. They're always with a staff member and they're always here. In our outpatient setting, we have up to 650 patients who receive services in our outpatient clinic. And our outpatient clinic doesn't only service people with mental illness. They serve people with, anxiety, panic, depression, bipolar, personality disorder, substance use disorders. So the variety of patients conditions that we treat in the outpatient clinic is far greater than the variety of symptoms from inpatient.
Oh, interesting.
Okay, that's thank you for that information. It does clarify this the presentation to me. And I have another question, please. I couldn't
Yes.
help but know
All
that
right, one more, Roxanne. I'll
Oh,
give you
but
one. Yes.
so we're only limited to one question concerning
No. I said you can go ask the next question.
Okay, thank you so much. I appreciate it. I won't take too much of your time. I'd just like to say, can I help see that beautiful greenery that you have? And just to mention, disclose, I am the founder of Friends Plum Parkway. I was hoping that perhaps you incorporate planting native trees and plants in your greenery, as well as invite community members in the surrounding area to join your efforts through volunteering.
Absolutely. So, this is a public space, and whatever ideas that people have about beautifying the space, we're interested in hearing about it to see how we can create it. We are creating a wellness center here that's really going to be a community space that will allow talent from the community to be able to provide services in our building and on our campus. We have a greenhouse, we have hydroponics, and we're
Wow.
actually going to be adding a greenhouse to our inpatient fresh air park. Our children's center next door, they have a lot more beautiful trees. So I know exactly what you're talking about. Yeah, we're interested in having more greenery on our campus.
And perhaps a community garden.
Yeah, we have
Yeah.
one. We have one on inpatient, but it's for the inpatient community. But that's something that we can consider for our campus here next to the wellness center.
Right.
I
Because
mentioned, I'm sorry. I mentioned the trees and native plants only because it helps environment, as well as alleviate the long hot summers that we have, the longer hot summers, as well as provide cooler shade and clean air for visitors and your patients as well.
Absolutely, yes. We love greenery here. We're into that. Greenery is very healing for the patients, along with the sunlight. So we do appreciate that.
I know
right,
that
and
I know there's lots of money going on for green infrastructure, which includes alleviating flooding and these hot heat waves. So I think perhaps you could even get some grants, perhaps, hopefully, to help get the materials needed to plant these native trees and plants, not only for beautification, but to help our planet and alleviate a lot of the symptoms of a lot of the effects that we have from these hot, long summers. And my last question is, and I've been on a plant-based diet for almost 15 years now. I cannot tell you how much it helps you mentally and physically. I could just say perhaps you could include in your classes or your what you mentioned about the kitchen, to introduce a plant-based diet. I mean, people don't have to turn vegan like I do, but at least incorporate some of it into their daily eating habits. And that's my last question. Thank you for your time.
Yes,
thank you.
Just to piggyback on that, so we have a nutritionist. It's a PhD. He's originally from the Bronx. He is part of a philanthropic organization that creates hydroponics on Bronx rooftops. He's partnered with us and is going to be creating hydroponics here. So we're going to have, food sources that are high in plant-based nutrients that we can provide for sale and also for the use on our inpatient services for our patients' meals. And in our fresh air park here on inpatient side, some of our patients, they grow vegetation that they use for certain events, and they're very proud of the plant-based recipes that they're able to create from
Nice.
their own sources of food.
Right.
Good.
Thank you.
All right, you're welcome, and thank you for your input, Roxanne. And I'm glad
Yes.
that you enjoyed our presentation. All right, anyone else? There were some people who were on and we don't know their names.
Now there's one person, the 718. I'm gonna, okay. They're muted and they're not, they don't want to unmute themselves, I guess.
Right, and who's the 347?
I don't know. Let's see.
I don't know.
No, I don't, that might be Jeremy. No,
No, it's not Jeremy.
347. I don't know.
I don't know.
I don't know.
All right, well, we know that we had some guests. I saw
Okay.
that Rich Reynoso was on for a while.
Okay.
So, all right, Dr. Boudreau, I thank you so much.
It is my
And-
pleasure. Thanks for having me. I appreciate
Well,
it.
thank you so
You're
much.
welcome. Thank you. All right, we will be in touch.
Yes, and we're looking forward to working with you, Bronx Community Board 11. We're looking forward
Okay.
to that.
That's
Excellent.
All right.
excellent.
Thank you so much.
Thank you so
Thank
much.
you. Have a wonderful evening. Okay,
You
bye-bye.
too.
All right. I don't know where the minutes are, Joanne.
No, minutes have to or will be submitted. The old
Right.
minutes will have to be submitted. I hurt my wrist, so it was hard typing. So sorry about that.
I'm glad that we were here. We were able to have this presentation,
Mm-hmm.
and I thought it was very, very worthwhile.
Very good. I had no idea we had so many resources.
Well,
Here.
I knew.
Bronx Psych had a lot, but I had no idea it was that extensive.
Well, that was one reason why I, pushed Dr. Boudreau to, do the presentation, because everyone has this, concept that everybody who walks on that campus is a psych patient.
Right. Well,
And
they
I go,
seem to have a lot of resources for the people who are there. I wish they were
Yeah.
bigger and there were more resources for more
Well,
people.
the idea was they really downsized the bigger buildings
Mhm.
and, made the smaller psych center more intimate and really getting to know the patients.
Very
And
good.
eventually those two buildings, the Parker and the Thompson, are taken over by Simone, and they will become medical facility. I think another hotel or whatever.
Oh, cool.
Yeah, so they're not going to be torn down. They were gutted, but they'll be utilized. All right. So shall we
Okay.
call this meeting to an end?
I believe we can.
Sorry, but I wanted to ask, I also wanted to ask something that was community board related. May I ask that?
Okay.
Well, if we could try to answer
No,
it.
I mean, even just make a little statement. It's regarding the minutes. It's not just particularly to this committee, but in general, the community board does not have minutes on a timely basis, and it's been going on for years. And I think I'm gonna bring this up at the leadership meeting, even though I'm limited to 2 minutes, so I'm not sure how much I can say. But I think there's an open meeting law that not only requires these minutes to be accessible to the public within 2 weeks of the meeting convened, but also that they must be posted now on the website.
Right. If I had an injury, so it was difficult to type.
No,
So
but
Right.
no,
But
but I'm
look,
saying,
usually my minutes go quick.
I'm just saying that it's not just this particularly committee. It's all throughout all the committees,
Right.
and it's been going on for a long time. I think there needs to be a solution, and I don't know why the leadership continues not to suggest that the staff does the minutes, because in other community boards, the staff does the minutes, not the board members who are volunteers, and many of them don't know how to do minutes.
I've never heard of that. It's always.
No,
I don't know, and I just
I've never heard of that.
And Roxanne, I just became the chairman because Joe Baycoat.
No, I know,
passed
and
away, so
you know,
when-
rest in peace, rest in peace. I'm so sad to hear that.
I know. So, I'm new at this.
Well,
But,
maybe if I get information from other boards, and perhaps I will clarify, since you have not heard of other boards doing minutes, maybe I will get.
Yeah.
I will get that clarification from
Right.
several board members, from several boards I have spoken to recently, but on my behalf. But there has to be a solution regarding the lack of minutes timely. And again, I'm not selecting this committee, it's throughout the board, not just, I'm not saying this committee, just because I.
all I can say is that if we don't have minutes at this, say tomorrow, they could look at the YouTube and see what really went on at this meeting.
Well, that's now, but before the.
Yeah, well,
No.
yeah, I wish I could really,
Okay,
say.
that was my statement. Again, I didn't.
Okay.
Well,
I didn't
thank
expect
you.
the resolution right this minute. I'm just stating that this should be something that should be really a priority for all board members, that to have a solution. And again, not towards board members where their minutes are done and when it's through staff. I mean, there has to be some solutions that are going on for years, and it seems like the staff doesn't really take it seriously, because there was 2 years ago where there was minutes missing for a committee for over 9 months. And when I mentioned that, they were not even aware those minutes were missing. I'm like, how can you not And then when I clarified with the chair, Alexander, he's like, thank you. We didn't even know that people were not taking minutes at the committee. We were assumed they were taking minutes. But I said, why wait 9 months? Why didn't anyone notify you that minutes were not being taken? But again, this is not particularly to this committee. So I thank you for your time and have a good night.
All right,
Okay.
have a good night, Roxanne, and thank you for your input. All right, have a
Okay.
good night. Joanne,
All right.
we'll talk. Have a good.
Oh, yeah, we got to talk
night.
about that other thing.
Right.
All right.
What I
Okay.
texted Al, and because I did it on my own donation to the American Cancer Society, and I thought that maybe the community board from the Friends of should give some a donation in memory of Joe.
Oh, that's an idea.
You know, they used to send fruit baskets. I know they haven't done that, or whatever they sent. So maybe that will be the way to go, a small donation in memory. And I think the family would appreciate it.
I wanted to send a mass card, but I don't believe they're Catholic, but I could just send a sympathy
No,
card.
they're not.
I do it on my own, yeah.
But you know, in fact, Yahi and I went to the funeral, and Yahi spoke there for a minute or two.
Yeah.
Very interesting, very different. I mean, because I'm so used to going to a funeral the next day, or
Oh, well.
or a day or two later,
Right.
not unless it's beyond, your circumstances. But it was
Well,
very nice, and a
yeah.
lot of music.
Oh, nice.
Yeah. So it was interesting, but I'll bring that up at the leadership.
Okay.
But I did, give it to Al because
That's a good idea. Instead of, we always send, little fruit baskets or something like that. And something like a donation to a charity might be a great idea for
Yeah.
board that pass.
Right. I mean, and we haven't done it in a long time.
We have COVID kind of,
Yeah, but I mean, this is an easy thing. You could do it over the phone. You could do
Right.
it in the mail and get it done. So that's it. But
Okay.
I'm glad that you learned something.
Yes.
And it was a lot, but
It was good.
it was good. And I mean, I knew about a lot of these places, and I have not been able to go because all our meetings have been virtual for the last 2
Right.
years. Usually I used to go and I would make on-site visits. I have the keys to the wards.
Whoa.
Oh, I used to go in the middle of the night in the old buildings. There was another board member, and we would get a call that they said, oh, the workers, when really not working late at night, they weren't around. And so we just had the keys, we parked the car, and we visited, and we found them in the sunroom.
Mhm. Oh, you know what? I have to call to
Go.
the end of the meeting. Are we adjourning?
Yeah, let's adjourn.
Okay,
Should I call
okay.
Jeremy?
Yes.
Should I call
Call
him
him.
and tell him?
Yeah.
Okay.
Call him.
I'm doing that right now.
Okay.